Assalamu alaikum and good morning, ladies and gentlemen. First, I'd like to request permission from our in charge Doctor of Physical Therapy, Professor Dr. Tahir to proceed with the event. Shall we proceed, sir? Well, I'm Dr. Sajjada Saifullah Khalid, lecturer, Department of Physical Therapy. Will be your host for the day. It's my great pleasure on behalf of the Department of Physical Therapy, Hamdard University Islamabad. We warmly welcome you all to our first international workshop on Cervico-Thoracic Manipulation at Hamdard University Islamabad Campus. We feel honored to have with us Dr.Mohamed Aldoliefy, a prime physio accredited tutor in United Kingdom. Without taking much of your time, we'll start the event with the recitation of the Holy Quran. I would like to call Mr. Noman to recite few verses from the Holy Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الرحمن علم القرآن خلق الإنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان والأرض وضعها للأنام فيها فاكهة والنخل ذات الأكمام والحب ذو العصف والريحان فبأي آلاء ربكما تكذبان خلق الإنسان من صلصال كالفخار وخلق الجان من مارج من نار فبأي آلاء ربكما تكذبان رب المشرقين ورب المغربين فبأي آلاء ربكما تكذبان صدق الله العلي العظيم.
Jazakallah khair. वो रोशनी जो मुद्दतों हिरा के गार में रही. Now I would like to call Miss Laiba कि वो स्टेज पे आके नाज शरीफ पेश करें.
फर्श फर्श पर आका आपके उजाले हैं फर्श फर्श पर आका
like to call Dr.Mohamed Aldoliefy, a certified kinetic control movement therapist, United Kingdom, certified Mulligan practitioner, Mulligan Concept Association, New Zealand, certified training practitioner, Australia, and a prime physio accredited tutor, United Kingdom, to join us on stage for the Cervico-Thoracic Manipulation. An ovation of applause for Dr. Mohamed Aldoliefy.
Yes, now it's fine. No, yes, I think. Can you hear me now? Or you can hear? Yes, I think this is better. I think this is better. Do you all hear me?
Yes, sir.
Yes. Welcome everybody. Sorry for being late. How are you? I would just like to ask you first one question. Why are you here? You must be here for some reason. Why are you here?
For learning.
You just happen to come by
To learn something.
to learn something. Why do you want to learn something?
To be perfect in our field.
Yes, to know the things we should do to our patients. It's our patient that's important. We need to give him the proper treatment, the tailored treatment. We don't have the stamp to give it to all the patients. We have to know the concept so we can apply it to our patients. Right? So now I can choose to do this to this patient, but I will not do it to this other patient because I have a reason. When you work in your clinic, in the hospital, and somebody comes in while you're working, what are you doing? I'm doing this and this. Why are you doing it? You should know why I'm doing it. It's why and the when. That's important. How you can learn it. You can have the skill of doing it, how to do it. But we are physiotherapists. We need to know why we are doing it and when. Should we do it or we shouldn't do it to our patient? First, my name is Mohamed Aldoliefy. I am from Egypt. I am a senior tutor with Prime Physio, UK. It's established in UK in 2006. Now we are teaching in more than 16 countries. This year will be first time in Indonesia, inshallah, this summer. And now mostly it's our work in the Middle East, mostly, and some UK, and we have done some courses in Malta and Sweden, but mostly in the UK and the Middle East, because we know the need for these professional courses. I graduated in Cairo University in 1998, then worked for some time as a clinical physiotherapist in hospitals, and now I'm a director and head of a physiotherapy rehabilitation center. It's not mine, I'm the director there. I'm also a tutor with Prime Physio. My main specialty is manipulation, spinal and peripheral, the intraneedle courses and the manual course, the certificate, orthopedic manual service certificate, we co-teach together, me and my colleagues. So let's start by this is Prime Physio. This is what I want you all to know. This was a saying by Ralph Waldo Emerson. He's a philosopher and American writer. When I read this for the first time, it stuck here. As for methods, there are millions and then some, but principles are few. We need a lot of methods, a lot of techniques, but the principles, the concepts, they are few. The man who grabs principles can successfully select his own methods. When you understand the concept, you can do any technique in this concept because you understand what you are doing. But the man who tries methods, ignoring principles, is sure to have trouble. Yes, I can see this technique on the YouTube, I will do it. I see my friend do this technique, and then I will do it. Then you will have trouble because you don't know why should I do it, when to stop doing it. It's the important is the selection of your patient. This is what we need to know today, some aspect about the manipulation. And know the safety measure we are going to do. Never do any technique to your patient without assessment. A proper assessment is your way to success. Because if you do the proper assessment, you will select the needed technique or method to treat your patient. Okay? So let's have a look about the vertebral. We are dealing about the cervical vertebra and the cervical vertebra. Generally, we have here the spinous process is nearly at the same level of the facet joint. Because mainly when we talking about manipulation or mobilization, we are talking mainly about moving the facet joint. So when I try to localize the segment I need, I would palpate the spinous process. It's the only part of the vertebra I can feel it under the skin. The other parts are deep in the body. I cannot reach it directly. So we have here one feature. If we look at the side of this body of the cervical vertebra, we will find it if the side is raised. It forms like a bowl, like a basin. So the other vertebra will lodge in it. This will have effect when we talk about the cervical spine manipulation. We will see it just later. We have here the foramen transversale and the transverse process for the vertebral artery, battling arm. So we need to check when we accept our patient, he doesn't have a pre-existing arterial dysfunction in the cervical spine. So cervical manipulation is not dangerous. It's not assessing your patient and recognizing red flags is what causes the problems we have with our patients. Okay. Now, if we look at the thoracic spine, we will find, if we compare it here, we will find the orientation here is about 45 degrees. We will see it later. But here, it's slightly up, about 60 degrees. And if we look, we will find the facet joint is looking slightly lateral, not completely in the horizontal plane. We have also here the facets for the ribs. So sometimes when we deal with thoracic pain, we may think of manipulating also the ribs here at these joints. One with the transverse process, one with the body. And one other feature, the tip of the thoracic spine is pointing down. So when we need to reach a certain segment, the facet joint, I have to reach up about a segment or two above, or segment from the half. So now here's, let's say this is T7. The facet joint of T7 will be about nearly at T6 or T5. So now we need to make it up, to go up for it. What about the stability? Because most of the time we hear that cervical manipulation is very dangerous. We cause this problem to our patient, or this he died, or he had stroke or something like that. This is not so. If you look at the spine, you will find it, we have two types of stability. The static stability here, we'll discuss, and the dynamic stability. When we talk about the dynamic stability, what do we mean? We mean the muscles. The muscles attaching to the spine is an inherent stability. We got the smaller muscles, the multifidi, reaching from the spinous process, between the spinous and the transverse process, short, small muscles. These are local stabilizers that check the translation of the vertebra against each other. But now we have also a static stability. We have ligaments holding the spine together, and we have the strongest, the disc itself. It's some kind of stability. The annulus fibrosus binds the bodies together. We have on the body the anterior longitudinal ligament. From the posterior, we have the posterior longitudinal ligament. This is the anterior compartment of the spine. What about the posterior? Let's have a look. The ligamentum flavum. It's a strong ligament. Intertransverse ligament. Interspinous ligaments between the spinous processes. Supraspinous ligament. So all these ligaments helping the stability of the spine. So if you look at the image, and don't just look at the MRI, this is just an image, this is anatomy. You have to relate to the symptoms with your patient. So you will not causing dislocation of the vertebra. If we are talking about spondylolisthesis, like in the lumbar spine, I'm not going to increase spondylolisthesis or the slippage of the vertebra. We have strong ligaments holding the vertebra together. So what about the facet joint? This is the target joint for manipulation. It's a symmetrical synovial blind joint with a fibrous capsule. We have here the facet joints, one on each side. This is the cord, and here is the spinous process. Let's have a closer look. Here is the intervertebral disc, the spinal cord here, the exiting nerve roots. We have the superior articular facet and the inferior articular facet of one vertebra. if we see the vertebra here, like this, I have the inferior articular facet of the vertebra above articulating with the superior articular facet of the vertebra below, forming the facet joint, or what we call apophyseal joints or zygapophyseal joints. Here you can see the cartilage of the joint. These are the lamina and the spinous process of the cartilage. So where is the location in the spine of the facet joints? It's located on the posterolateral aspect between the pedicle and the lamina. The pedicle means a leg. We have a body and then we have a leg. Between them, we have on the posterolateral aspect the facet joint. Okay? It forms what we call the articular pillar of the spine. So, why do we feel sometimes pain and restriction? Because we have innervation in these joints. And it's dually innervated. It have two branches innervating it, all from the same side. So if we think of the facet pain, the picture of facet pain, it mostly would like be a localized pain on one side. We don't have a pain across the back. When we have a pain across the back, we may think it may be a discogenic picture, not a facetogenic pain. We say maybe because we have still some probability of other problems in the spine. You will never be 100% sure it's exactly facet or it's exactly disc. So it has one branch from the vertebra above and one branch at the same level, all coming from the dorsal primary lemma of the spinal nerves. It's called the recurrent meningeal nerves or the recurrent nerves of motion. So what are the functions of the facet joints? We have a structure in the body, it must have a function. So what do we think the major function of facet joint is? What do you think? You can read. What do you think? We have a joint. What's the purpose of a joint?
Range of motion.
Range of motion. So it gives us the range of motion of the spine. I move, you flex, you side bend, you rotate through the facet joints. It allows this range of motion. So this is the main function. And we have another function. It acts as a shock absorber with the disc. It's like a spring. We have, when we ride a car, you have springs near the wheel to a shock absorber. Otherwise, the shock would come. And all the stresses coming down on the spine will be on the disc. This is too much for the disc. It carries from 20 to 30% of the body weight. So it decreases stresses on the disc. When I jump, when I move, it acts as a spring, like the joints of the bridges. It relieves stresses. So it's important. So when we have a problem in a facet joint, we will have pain due to the nociception around the tissues around it, and we will have restriction of movement. This restriction may be some kind of disrupted capsule or anything that happened, or from the pain itself. Pain causes inhibition of movement, some dysfunction. When I have pain in my arm, or I feel my arm is weak, it's not weak, it's inhibition caused by pain. So we need to restore the normal function through what we do. It's the movement we do. Exercise mainly, mobilize, manipulate, but always go for the exercise. When we exercise, we move the joints, we move the muscles, we move everything. What about the orientation? What's the importance of the orientation? The orientation is the direction of the plane of movement in the joint. In the cervical spine, we find it 45 degrees to horizontal. So it's like this. This is the horizontal, it's like this. How can this help us? When I have the facets like this, I can do flexion, extension, side bending, rotation. So I have a greater degree of movement. This is needed for my head, for my pants, and for vision. Otherwise, when we have a stiff neck, like the wry neck, when I wake up in the morning, slept in an awkward position, now I'm stuck in this position. So I have to look like this when I need. But when I'm having a normal neck, I can look. So this is important for us. But what about when we go down with the thoracic spine? Now the angle changed, it increases to about 60 degrees. Always, when you think about the orientation, think that the facet joints are looking to the eyes. So when we are in the upper cervical spine, we will find the direction of the facets horizontal. So it allows only rotation. Because it's horizontal, it allows only rotation. And the other movements are checked by the ligaments. But then it starts to look up. In the thoracic, it looks more up. In the lumbar spine, the eyes is directly up, so it looks 90 degrees up. But it's not just 60 degrees with the horizontal. It moves to the lateral about 25 degrees. So it looks slightly outward. This will limit some of the movement. It will limit flexion and extension and some side bending, but it will allow a greater degree of rotation. And this will also cause the thoracic curve, increasing the lordosis, here the kyphosis, sorry. So when we have some kyphosis, we increase the chest cavity for respiration. We limit the movement for the respiration. If I have greater amount of flexion, I would collapse my lungs and my heart. So the orientation here, as it helps in the range of motion and limited, it also helps in the function of this segment. So we have to respect these rules when we manipulate. We manipulate in a direction that's allowed for you to move. Will it work or not? We try to work this.
In this video, we're going to be talking about superior facet orientations. This is something that you need to know the context. So first of all, what are we even talking about when we say superior facets? So if we zoom in, let's look at the cervical region here. And if we take C4 here, now the top part of C4 is going to be the superior articular facet. And so if we look at this in context, we're talking about this part right here. Now this part is articulating with the inferior facet of C3. Now what we're talking about here is simply the orientation of the facets. So what do these facets here actually look like? And they're going to look different between the cervical region, the lumbar region, and the thoracic region. So to take another example, in the thoracic region, if we hide this one above it, what we're looking at are these facets. Notice how this is a little bit different than So let's start a chart. On the left side, we're going to have location. On the right side, we're going to have orientation. So what do you need to know? In the cervical region, the superior facets are oriented backwards, upwards, and medial. So that should be easy to remember. So let's take a look at one of the cervical levels. So upwards is here. Medially is kind of hard to see, but you see on the side there's a little elevation, so there's a little bit of medial. And of course it's backwards. It's facing the back. In the thoracic region, the facets are oriented backwards, upwards, and laterally. So if we take a look at one of these thoracic vertebral levels, let's pick this one for example, and we take a look at it from a posterior view, superior facets here are located mostly backwards and upwards, and I guess they say they have a little bit of lateral in them, which I don't really, it's kind of hard to see the lateral. Let's pick another one and see if we can see it. So this is just to give you a visual. Now this is considered backwards, again, upwards, and lateral. So you see that there's a little bit of a lateral turn to these facets. And then we have the lumbar region, which is the most distinct, which has the same orientation as cervical. Usually they just say in books backwards and medial. So we take a look at the lumbar region. You'll notice that these facets here are backwards, upwards, and medial. So they're kind of angled in a medial direction. So that's really all you need to know. The cervical region, you can just consider cervical and lumbar as the same. So the cervical region is going to be backwards, upwards, medial, thoracic, lateral, lumbar, medial.
As we see the different orientations of the facets will guide the movement for us. So this is how we move. But there's some other concept we need to know. What do you know about the coupled motion? When I say a coupled motion, what do you understand from this concept?
More than one movement.
Yes, more than one movement. So,
That is called.
yes, because it's a couple.
Yes, combined.
Yeah. So there is a difference between combined movements and coupled movement. What is the difference? Just think, what's the difference? When I ask you, what do you understand when I say combined movement? What do you will say?
Two joints.
Different movements at the same point.
Meaning,
Movements creating a single motion.
combined movements are two movements happening at the same time. So now I have extension at the same time I will do rotation. So this is combined movement. This is the outcome movement, the active movement. Doing two movements together, I do it. But the coupled motion or movement is movement happening together. Each is necessary for the other to happen. Meaning, and it's at that segment level. So for each vertebra to rotate, I need another movement to happen so I can complete this rotation. Otherwise, I will not be able to complete rotation. So it's always the side bending is coupled with that rotation. We talked about the elevated sides, right? The sides of the vertebral body is elevated. So what happens? Let's see, I have elevation here and I have this body inside, right? So I need to rotate, but what will happen to me? Rotation, we mean the body rotates, not the spinous process. I'm not talking about that, I'm talking about the body. Here is the body. I need the body to move to this side. What will happen? It will be stopped by the raised bar, right? So I need to tilt this body slightly down so I can have more range for more rotation. So that's what we call the coupled movement. We need to just move it a little to give us a space to move. So it's always rotation and side bending, but it differs. In the thoracic spine, in the cervical spine and upper thoracic, that's up to T3, down to T3, we have rotation and side bending going to the same side. So if I need to rotate to the right, each vertebra have to have some tilting to the right. This is some side bending happening to the right to allow me to do the rotation. Or if I want to do side bending, I would have to do some rotation. But in the lower thoracic spine, this is not the case. It's inconsistent, meaning I don't have a rule. Each vertebra may move in a different way. Why? We don't have the elevated sides, and then we have the ribs connecting it to the internal anterior. So this is why it moves. Okay. What had this to do with the manipulation? I need to put tension to get to the end of these ranges, and then I will push the vertebra, like we will see. To get to the end range, I need to arrange it in the proper orientation and coupled motion. And sometimes we will do combined movement, not to the end range, because if I reach to the end range in a combined movement, I will restrict all other movements. If you reach down to the full flexion, you cannot rotate, you cannot side bend. So you limit all the other movements. This is not what we do in manipulation. In manipulation, it's a mid-range movement. End-range movement will cause problems. It's a mid-range movement, always, even in the thoracic. Here is the coupling. As you can see, here is the raised sides. This is what we need to avoid. Okay. So now let's come to the manipulation. What is manipulation? We use this term, but what is it? It's a passive technique, right? You do it to the patient. He's not doing it. Yes, some patients can crack themselves, but this is not the main procedure. So it's a passive technique. Perform it to a joint complex. You are not doing it just to the articular surface. You are affecting the capsule. You are affecting the muscles, the ligaments around it. A lot of forces come into this. When you mobilize the segment, you have movement in another segment, more distal to it. And we will see what happens with manipulation. So it's a passive technique. Perform it to a joint complex at a high speed, low amplitude thrust. Thrust means a quick push. So we have features different from mobilization. Mobilization is a low speed. Manipulation is a high speed. Mobilizations have varied volumes of moving or varied amplitudes, but manipulation is always short amplitude, low amplitude, small movement, quick but small movement. Okay? That's beyond patient's voluntary control. The patient cannot control it. Once it starts, the patient cannot stop it. And it's usually accompanied by a clicking button or sound. We usually have a sound. So this is another feature of manipulation. We need to hear the crack, the pop, the sound. Although We have some people in this side would say, no, I don't care about the sound, because sometimes I get a result without hearing a sound. But this side will say, no, we have to have the sound to consider it as a manipulation. So we will always have conflict. Okay? So now I want you to discuss it together, but discuss it effectively. Meaning, you come out of the discussion with torn clothes, blue eyes, broken teeth. You know this discussion? I am right, no, I am the right one. So it's a debate we need to do a lot. So don't just focus on the sound, but focus mainly, that's what I need to do, on how you put your patient and how you deliver the course. This is what is important. If you do this, most of the time you will get the click. If you just go look for the click, you will fail to get it. Okay? So what we do want to get out of this, we need to know or to understand what is the cervico-thoracic manipulation for this area, because we can do it to a lot of joints, all the joints. And we need to have some confidence in doing the manipulation for the thoracic and some for the cervical. And it's a tool, you can add it to your toolbox. When you need it, you get it out and use it. Okay? So what are we after when you do the manipulation? Why are we doing it? We are doing it for hypermobility and range. Meaning, we need to increase the range and to increase the pain. This is our aim for doing the manipulation. Not to correct deformities. Okay? So because some people I will correct kyphosis, I will do for scoliosis. Not so. Okay? Okay, I need you to know where are you moving inside the range. Right? If we look at the range here, we have here is the neutral position, the mid-range. And then we have this white area, zone number 1. This is the active range. Beyond it, we have another area, blue, darker. This is the passive range. We still have some small range called the paraphysiologic range. That is number 3. Then number 4, we get out the anatomical integrity. This is the end. After the paraphysiologic space, we have the end range. If you cross the end range, you will be in zone number 4, that is sprain or injury to the joint. In the active range, we do the active mobilization, which is that exercise and active. I mobilize when I flex and extend. This is an exercise. This is active mobilization. I move, mobilize the joint. In zone 2 or the passive range, we have mobilization and stretching. I go more. This is I can have it active, but I can have it passively done to me. Here is the end range of my elbow. This is the active range. Then I have some degrees of elbow flexion. This is the passive range. The range for mobilization. Then you cross the limit and you reach in zone number 3. We have a small zone here. So I need velocity to cross the barrier, right? If I don't have the velocity, I will not be able to cross this barrier to get into zone number 3. That's the paraphysiologic space. I need to have a speed to cross the barrier, but I need to be very small movement. If I have a larger movement, I will go beyond the normal range and cause injury. This is what happens in falling or accidents. You have a very fast force and a large amplitude. And suddenly he will see his joint dislocated because it's a large amplitude. That's why we have high velocity, low amplitude thrust. But what about the effects of the manipulation? We have three main effects. Mechanical, because we do mechanical force, then we have a mechanical response. And neurophysiological response. And then we have also a psychological response. What about the mechanical? We restore the tissue extensibility and range of motion. Of course, when I do manipulation now, try to move, yes, that's better. This is a mechanical effect, right? You elongate the connective tissues. If I'm not moving and I'm still in a slouch positions, what happens to my soft tissue, the tissue around the joint? It will shorten. Not shorten, it will get used to this position. When you try to stretch it, it's not used to it. By doing the manipulation, you restore this connective tissue. You disrupt the cross linkage. If you have a problem and you don't move, your collagen fibers will turn from type 1, which is packed and parallel to each other, it will bring cross linkage like this. This is not good for loading, because if you load, you will stretch on some fibers. This will cause you pain. So with loading, that's the exercise, the mobilization, the manipulation. You arrange them back and disrupt this cross linkage. So you arrange them back in the normal alignment, allowing better movement and less pain. What about the neurophysiological? This had the most evidence. Now we have a lot of evidence regarding these. Okay? We cause what we call hypoalgesia, meaning I decrease the sense of pain by moving, the perception of pain. Athletes have a lower sense of pain. They can tolerate pain more than people who are sedentary in life. If you move, you raise the threshold of pain. So your pain sensation will get less. So this is what happens with manipulation. You activate the mechanoreceptors, type 1 and 2. This will transfer the signals. The signal is transferred through A delta fibers much faster than the pain signal in the C fibers. So it closes the gate to the pain. We use gate control theory. This is proved by research and clinical evidence. We trigger the descending pain inhibitory pathways in the brain. We use the preaqueductal area, the internal opiates, the secretion of the internal opiates. So I am feeling better. You invoke autonomic nervous system response. This will cause more pain relief and restoration of movement. You have a peripheral and spinal mechanism. This is the local reflex regarding the muscle spindle. You increase the activation of the muscles. You decrease the superficial and global tone. All these are the effects of the manipulation you are doing. And then we have the psychological effect, the placebo effect. I will do something to you, my patient. He trusts me, so he believes me. I will do this technique to you, I will crack you, and you will go run like a horse. He believes this. He gets the results. It's your instruction, effect of your instruction. We will do this, you will be good, then you will do exercise. You are precise, persuasive, he will get an effect. And also he expected to be right and good, to be fixed because he heard his brain got manipulated and was better. So I was gonna be better. What about the sound? We hear a sound. Why the sound happens?
It's a locking and unlocking of it.
Let's look here. I can see here. Can you see here? This is the knuckles. Manipulated. What we suddenly you will feel here is a small blackness. We have it quickly. Black in an image means air, gas. So we have the evidence that we have had this. When you do a quick movement, there is a sudden drop of pressure inside the joint. This will cause some of the synovial fluid to turn into vapor, to gas. This gas forms bubbles, but these bubbles are not stable. It will burst quickly. So one bubble second. It's like you have a lot of balloons here and they will start pump, 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 pump. What will be the voice you hear? Pump, 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 pump. When you, all of this combined, you would hear it outside. So this is what we hear. This is why we need the quick movement. If you don't do the quick movement or the velocity, high velocity, you will not get the sound. It's the second. But if you click somebody or a joint, you need some time before you can click him again. So it's about 30, and now we consider it about up to 1 hour in some patients. So I will not do another manipulation because I will not hear another sound. If you want the sound, you have to wait for at least a month. And usually it happens on the opposite side of your force applicators. Meaning if I'm pushing from this side, right, I will get mostly the effect on the left side, in the cervical, and sometimes also in the lumbar spine. Okay? And this will also transfer the force to other segments. So you will feel more than one segment cracking, not just the segment you are pushing. You will feel it to yourselves today. So we have evidence also it acts, it has a better effect than massage. This is one research. In another research, we have some minor effects because this is very minor, up to 7 days. So sometimes it's some kind of soreness. When I do manipulation, some patients may say, oh, I have this pain. It's not my pain, but it's a new pain. This is soreness. Don't worry about it. It's minor. It's safe. It's a side effect. Some dizziness, some headache. Don't worry about this. This can happen up to 1 week after the manipulation. It increases the disability and increases range in neck pain. This is in 2008. It decreases pain even in the elbow, lateral epicondylgia. So when you do cervical or thoracic manipulation, you may have effect on the shoulder or the elbow. This is what we call global effect. It increases. Here it was done to the cervico-thoracic junction and it has an effect on C1 and C2. Although you have done it below, but you got the effect even up. So you can use thoracic manipulation to deal with some cervical problems. Okay, now, when not to manipulate my patients? Which patient will you will say, no, I will not manipulate him? Fracture, sure. I would never move a fractured side.
Old patient. Old.
Old? Maybe I will be cautious, but not absolute. I would usually not try to manipulate my patient. Tumors.
Arthritis.
Sprain?
In-level osteoporosis.
You mean instability? Yes, if I have an instability. Yes.
Multiple artery infections.
Yes. Good. So if I have the first, I have a low lack of diagnosis. Lack of diagnosis meaning I have not examined my patient. I haven't done my assessment. So I don't know what's wrong with this patient. Don't manipulate. Instability like fracture or sprained or ruptured ligaments. Bone tumors, like you said, infectious diseases, TB, osteomyelitis, spots, whatever. Other motor neuron lesion, like spinal cord injuries. You never manipulate this patient. Cervical arterial dysfunction, like the doctor said, if I have some arterial problem, I will not manipulate my patient. If I have multi-level nerve root pathology, if I have unremitting, mean a severe pain not responding to treatment, non-mechanical, because it's non-mechanical pain. Why should I treat it with a mechanical treatment? If I have a neurological signs that's worsening, like coda signs in the lumbar spine, any pathology leading to bone weakening, because I may cause fracture, vascular or bleeding disorders like hemophilia, I will manipulate this guy. If he cannot be in the position to manipulate, or if he said, no, don't manipulate me, he's fine, but he doesn't like manipulation, I will not manipulate this man or this patient, right? But in the course or in the workshop, nobody would say no, don't manipulate. So you will be model for each other. There is a relative contraindication, meaning it's a more of a precaution rather than a contraindication. If the patient is not responding well to manual therapy and have some adverse reactions with manual therapy, I would need to check more and assess more to find if I missed something. With some inflammatory arthritis like rheumatoid, I may manipulate or may not, so I need to assess him properly. Pregnancy. Some ladies have spontaneous abortion, so if you manipulate, then her folks will come, you cause the abortion. They need somebody to blame. It will be you, mostly. So for pregnant lady, mostly I will not manipulate. Osteoporosis, I need to assess, is it very severe, so I have a precaution, or it's just general osteoporosis, so now I can also manipulate. Okay? Anticoagulant therapy for fear of bleeding, long use of corticosteroids, this is bone weakening, laxity, increased range of the ligaments, I will be cautious. Fever, mostly feverish patients, I will not manipulate till the fever goes down, because I don't know what's wrong. Maybe it's some systematic disease. And if I have a history of cancer, I need to be sure he is not having a metastasis or the cancer is back. So you need to recheck. Have you checked with your oncologist? Yes. About 7 months ago. This is too long. Please go back, check, and come back to me. Okay? If I have a severe spinal trauma, history of severe spinal trauma, I will be cautious with these patients. And if I have regional restraints, I'm coming with rhinic, I cannot manipulate this man. He have a heightened sense of pain. I need to correct this shift and manipulate him. In the lumbar spine, it's coming like this. I need to correct him to the neutral position before I will do the manipulation. So let's do the practical part. Who would be here with me? Welcome. How are you today? Fine. How's your baby? This is usually what I gave you exercise. Have you done it? Yes. Okay, let's do the manipulation. Okay? And you need to be very gentle with your patient. Lie on the bed. Yes, you have to be. Give him your authority. No. Okay, one thing. This is not proper for manipulation. It will dissipate your force, may cause something. So now I need him to be on this side. Can you be on your face? Yes, better. Can we have a towel? Just one towel. We need to manipulate him in extension for the thoracic spine, meaning I need to put him in an extended position and then do the manipulation. So it's not for extension, it's in extension. It's usually done by having him sitting. But until we get the towel, I can do it in another way. I can do it when he is prone. So can you be on your face? Lie down, head like this. Lie down. Then I will get his hands out of my way. Why? This would slightly move the cabin away from the thoracic spine. Okay? Now, get a large piece of wood. This you will manipulate everything. Then this I need to be sure he's comfortable in his position. Get your head to one side. Are you comfortable? Yes. Now I can start. Here is the position of manipulation. Okay. Now, to do the manipulation, I need to reach the end range. If you are away from the end range, then when I push, it's like I'm falling or giving him a blow. Take the soft tissue slack. I cannot reach to the posterolateral aspect. Okay? In the thoracic spine, we need to do combined movement, but this cannot be done. This can be done in the cervical or the lumbar. So I have to do all my manipulation from the posterior. This is the only way I can reach to the vertebra in the thoracic spine. If I come to the sides, it's the ribs. So now I am on the spine. Here is the spinous process. I don't need to push on the spinous process. It will cause him more discomfort. So either I put my hands like this on the transverse process around the spinous process, or I can put my hand like this with the spinous process in between here. So these two parts, the hydrocerebral and inner ribs, are on the transverse process. Do it in the transverse process. Now on the level here, now I'm pushing down using my weight. It's starting to crack. This is what we call sit-up. Take a deep breath. Out. At the end, I would push down. Not straight down here, I would slide down with slight angulation upward. Then why do we tell him to take a breath and out? This is a relaxation. And to synchronize my push with his exhalation. Goes up. Here is the spine. If you inhale, you expand. If you push at this point, It's as giving him two opposing forces. This will cause discomfort, cause him pain. So always push at the end of expiration. Go with the movement. You are going with that movement. So now, this is manipulation in extension. This can be done like this. If I have a high table or a large patient, I will go up on the table and push on him. Or I can do it better with him sitting. Can you sit facing them on the bed? I will remove this for 1 minute so I can. Then I get a towel or a sheet like this, and then I will roll it. And I will put it. Can you stand for just one? Give them your back. I put it at the level I need to manipulate. Now it's on. I have my fulcrum. Then I will put my sternum in here. I will use my sternum as a counter force. So now I will give the force from his arms toward my sternum. It's like this. See here is my sternum. This is the movement, but a quick movement. Now I'm pushing from here and stabilizing. It's here. See, I'm moving him into extension. You can see some guys do it with their friends. You carry him and doing this. Yes, it can be done, but this is not the default. Why should I carry my patient? Yeah, you may carry him and you will end up, you and him, on the floor. And this is not good for you. So sit on the bed, come to the edge, at edge, sit, come back toward me, at the edge, come back toward me. Come. Don't worry, sit back, go back, yes. He's at the edge. Now, I will put the towel, I will take this step. I will need this better. Some of my taller colleagues, Dr. Abdurrahman, he was teaching with me, he now is in the UK, he would have to be like this. This is better for him because he's tall. When he stands like this, he's still too tall. So it's better to stand like this, but stand like this. Now I'm putting it here. It's in my sternum. Hold yourself, hug yourself, love yourself. Now I'm holding his lower hand, not the upper. If you push on the upper, it's mostly on the shoulder. But now he can feel the movement, the tension on his thoracic. Now I'm holding him. I'm asking him to get this down. Otherwise, it will hit your face and remove your face away. Now I'm holding him, hug him toward you, give the tension, take a breath, out, and then I will pull. How many cracks did you feel?
5 or 6.
5 or 6. So I was starting one segment, yet I had multiple, because the force transferred to other segments. Now you can tell. How do you feel? Very good. This is the thoracic manipulation. It's very easy. Okay? You can do it from roll or from sitting. Whatever you like. Then can we if we go up to the cervico-thoracic junction, or from C3, C7, T1, T2, and T3. This is what we call upper thoracic or cervico-thoracic junction. Okay? We can do it in rotation. So, can you be on your face? I will do all the thoracic, these two techniques, we will do them practical, and then we will come back to the cervical. I don't need this, relax. So I would use him as a carrier. Now I can Hold him. Go slightly back. I would ask him to put his hand here. And I would ask him, look at your fingers. No. Look at your fingers. What did this do to him? He has rotation to the other side, right? And then when he looks at his fingers, it's up. He gives me the side bending I need. So to manipulate this area, I need him to rotate to the opposite side, side bending toward me. I'm here to give the push. Here is the manipulation at the right side. So he's side bending to the right, to the same side of the manipulation, and rotating away from the manipulation. Up. This is not important in that manipulation. It's just a way to place him. I don't need it, but just this hand goes out of my way at his side. Then what do? I will use my thumb. Here is my hand like this, my both hands like this. This hand toward me will go down on his shoulder like this, and the thumb will be at the side of the spinous process, pushing it away to the opposite side. So if I have the spinous process like this, I'm pushing it this way. So now I'm rotating the body. If I have the body here, if I put the spinous process, what happened to the body here? It will rotate to this side. It will rotate to right. So now I'm doing rotation. Do we get rotation of this vertex? But if I just push, his body goes with me. I need to stabilize his body. If I stabilize here, still not good. So now I need to stabilize the lesser part, the head. How can I stabilize it? I will use my other hand, that's the one near the legs, to be placed on his cheek. Now I'm stabilizing and giving him tension. I'm not pushing by this hand, just stabilizing. And give the tension backward, and then go slowly with this hand until you reach to the end of the available range. Reach the end. This is what we call tension. If you get good tension, you do the tension good, then do the thrust. If you are away, it's like I'm poking him with my thumb. So now he can feel the tension. He cracked just by push. See? Quick push. But the good setup, he cracked even before I gave the push. Right? Come to the other side. Let's see. This side. I will be here so you can see. Can you all see?
Yes.
Now I'm here. And then I will push. And it's easy. He cracked. So don't worry about it. It's very easy. So this is the cervico-thoracic and the thoracic manipulation. Shall we try to do it? Can you come? Try to do it? Come. Get to do it. Right there. Let's come up. He's already cracked, so you will pick up anyone? No. You are not telling him. Just see, go, catch him like this. Thank you. Are you afraid to do it?
Yes, sir.
Why? Because what? It's the first time.
Yes.
So there is a first time for everything. Get up around your feet and try to do it. Okay? So try to come around. Get up. Where is everybody? Who will do it? It's your show. You are the stars here. come and shine. Twinkle, twinkle, little star. You know this problem? Come. This is not test. This is you need to know. It's easy to see, but you need to put your hands, get the feeling of it. Can you try the extension? Get the tension. Push this. Don't give the thrust. Push slowly down, 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 down. Listen. Take a deep breath. Out at the end. Push quickly. See? Quick. Push, push, push. This down and quick. Again. Go slightly down in other segments. Because this is not the beginning. See? Here. And take a deep breath. At the end, I will move down. Right? So can you try it from sitting? Here, okay, from sitting. Good. Now, if you put it here on the abdomen, this is soft. This will not give enough force. For the ladies, you need to put it up here, above the abdomen or the breast tissue. I don't want cushions to dissipate your force. You need bone. So try to keep it above you. Give the good tension and then, yes, go down. Bend your knees slightly. Yes, you're in the middle. Now you can bring him by leaning him backwards. Put it in your sternum. Good, good, good. Now, he's not holding himself. Hug yourself. That's good. Hold the lower elbow. Relax your knee. Yes. It's good. Hold the lower elbow, not this one. Hold the lower. Then lean him slightly toward you. Hug him tight, tight. Pull, 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 pull to the end. And then give a quick thrust. Now see, quickly toward him. Here. Like this. Push, quick. This is how it starts. Okay? Thank you. Can you do him the cervico-thoracic, the rotation? He's doing good because once I have a patient who didn't take off his shoes. Then all the day I told him to stand for the facing the wall and sit like this. Yes, it's very important for your patient to remove his shoes. Why? First, he will be relaxed. He will not be relaxed with shoes on. And second, this is most important, he will dirty your sheets. And then you have to. Now, this is important because he has to remove his shoes. Every time, please remove his shoes. Because I see patient who's too lazy to unleash their shoes. No, please remove your shoes. Now, get him down. Get down. Get down. Again. Again. Come towards him. Always try to bring the patient as near to you as possible. Now you need to be on him to place yourself. Come to this side. Get your hands here. Now he's in rotation and side bend. Can you try it? Extend your hand on his cheek, not on his ear. If I put it on the ear, he will say I. You will cause him pain. Now that's good. Extend your finger. Here is the spinous process. Get near it. Do this. Come up. Stabilize. Push in here. Stabilize and push to the end, and then give the thrust with this hand. Okay. See, I'm stabilizing, pushing. Get to the end. Boom. Like this. See? Yes, better. Again, try it again. Don't worry. Good. I hear the click. So he can get a click. You can get it. Thank you. Forward, come up. Come on. Come on. Yes. Choose somebody to do it with him. Anybody? Try it. Come. You can come, boss. He will be the model. So if he can lie down. Now you have several patients. You can do it to each other and on him and see the difference of the bodies. You need to do it for different bodies. One thing, he needs to really relax. Now I'm not using this here, but I need him to be relaxed. Good. One small thing, I need him to get this hand. Can you come to this side? Come to this side. Again, come. He's near to you. Relax. Now what you did is you just pushed up. See what happens when you push up? Your hand slide on the clothes or the soft tissue. But I need to, I am on him. See, here is my body. Using my body weight, now I'm on him and then I will push down. More down than up. Get on him. Yes. Get on him. Yes. Put all your weight on your hand. Then take a deep breath out. When he is finished, at the end, push. Good. Down. Push down. If you cannot do this like this, we have some solution. Okay, go to the other side. You can go up here on your knees. Yes. Yes. Go up. Now, put your hands down and push down. Down. No, not up. Down. Yes. Better. See? Can you try it? You can try it when sitting. Try to do it. Get you down, hold your weight, better. Keep down, see? I am him. Now, here, push down, see? Push down, don't push. Quick, use your body weight. Both are right. Yes, both are right. Like this. Get down. Yes, yes, yes. Down. Push to. No, not like this. Like this. Yes. Better. Okay. Now, can you try the Cervico-Thoracic? It is rotation. You have to side it. Now, get your hand here, stabilize on the cheek. Push it like this. Get your elbows in. Come slightly up. Yes. Get your elbows like this. Now, see, you can stabilize better. So my elbows like this. Don't push down. Push toward the other side. Get to the end. Not by this. By this. Wait. Why is that? Why did she didn't? See, you need to get in. See, get in. This is the tension here. See, try on the other side. Because he crashed on this side. So it's easier. You need to get the tension. Very good. Now, stabilize. Very good here. Push it here. Stabilize. Then get it in, and then quick move. Yes, that's straight. Now, this is like I'm hooking him. Get your elbow, flex your elbow. And yes, push in, and then hook, quick push. Yes, that's it. Okay? Here, and then out push.
And the sitting one.
Yes. Thank you. You need to do it. They will do, and then I will do the cervical. Thank you. Down and slightly up. Maybe down. See, like this. Get your body on here. Yes, that's good. This. Not too much up, but yes, try it like this. Good. Try the rotation. Yes. Put it here. Bring it inside, flexion. Get up on him. Flex your elbow. Just relax your arm. Relax your arm. Here. Now, get your thumb like this. Put your hands, make this. To the side, flex your elbow, wrist in, and then push with this hand. Not from here. Push, relax. Push. No, not to this thrust. Get in, and then give this thrust. No? Slow. Stabilize. Take this, slap, push. See how is my hands moving? Here. Better. But you are too much away. If I'm too much away, it's like I'm hitting him like this. We need to get in. Relax. I'm getting in. See? He can feel it. You are here doing this. Get to the end and then. Okay? Thank you. Come up. You are on the table. on your back. On your back. Subai. Subai. Yes. Now, mostly to do the cervical manipulation, I need a pillow under his head. But we still can do it. Come slightly to the edge. So now I need his head at the edge. I will stabilize him. Now I need two movements, like in the cervico-thoracic. I need to rotate away from the movement and to side bend toward the movement. So if I put my hands around his head down like this, and then I will ask him just put it on my hand. This is mid-range rotation to the opposite side. So I come with this hand down to the level I want using this part. This is on the posterolateral aspect here, like this. And then I will use my hands to rotate. See? It's like this. You hand in the bowl. Sometimes we hold the bowl and do it like this, right? So now I'm holding, get the tension. Now translate, move the neck to this side. Then here is the tension. 1, 2, like this. Small rotation. Here is my side bending. By moving my hand, translate, and then I will do it. Click. Right to the other side, here. Small rotation, side bending, translation. My finger, thumb on the jaw, not on the neck. Okay, or I can hold it like this, get the tension, and then push with my hand. Okay? Try to the other side. Yes. Hold it like this. Get it to down. Yes. Mid-range, side bending. No. Get side bending, translate, and a quick movement. Yes, that's it. Okay? So, small rotation, small side bending, and no increased rotation. Some patients do it to themselves, right? Good. And this is the rotation. Also, always in mid-range, there is no too much range. It's safe practice. If you are in the mid-range, it's safe. Your positioning is not different from the, you can sit, thank you. It's not different from the normal range of motion. So you will not put any danger to the vertebral artery. Okay? You will not cause any undue stress on the cervical spine ligament. Don't worry. You will not cause him to fracture and die. If you see the American movies coming from behind and doing this, especially the military, this is not going to happen. So don't worry about it. Okay? So it's safe to do it. Just get the tension and then do a small movement. Quick, small movement. Okay? Can we try? We have some practice, or then you should practice here? We should practice here. Should practice here. Who would like to try? Come up, both you. Thank you. Gentlemen. Come up. yourself. Don't be like this. Don't bend your back. Good. To him, get near his head. Yes, like this. The other side. Rotate. Side bend this way. Now, knees and push, try to push, and then try to rotate it. Yes. Now, the other, increase the rotation. Here, let's see. Relax. Now I'm holding, slightly letting his head resting on my hand. Here, my hand, your hands here. You have rotation, you slightly move this way. Here is the side bend. Push in, and then try the other side. See, it's not hard. I'm not going too much force, small force. This is too much rotation. Slight rotation, this rotation. Side bending this way. Okay. Relax your hands. Come towards him. Then push to the end here. And then quick rotation. Both your hand. Quicker rotation toward. Take it breath. Don't tension yourself. You can do it right. Good. See? Give the tension. Ease the tension. Now, I'm getting the side bending. I'm pushing. Here is the tension. And then move. If you not get the tension, you will get the crack. So try it. Quicker. Try it again. Quicker. That's her hand cracking. Now, she have done the manipulation. Why? Because she's tense. She needs to do it right. Don't tense yourself. If you are tense, the patient will feel you're tense, and he will be tense himself. Now, just one place. You have to look into his eyes. Make him ready. Yes, sometimes I would joke with my patient. I would joke with him. Why? I need him to be relaxed. Because sometimes I am a trained physician, and my colleagues sometimes will try to manipulate my neck. Sometimes I'm neck. I'm not sure about his ability. I'm sure about his ability. But this is what happens with most patients. Relax. That now I would start. See, here is a small rotation. Side bend. Distracted by just you. And then I will do quick small movement. He can feel the crack. How many cracks did you feel? Mainly most of the segments. So it's not too much movement. Okay? Try it. Again, try it. He already tried that time. Get another one. Who wants to do it again? Let's have some. If you want to learn something, do it. Come up. Try to see it's like this. I have here small rotation, small side bending, tension, and then small movement of rotation. Not too much. You can feel it here, and then I will do it to myself. Good. suggest you can try to learn and then with the tension, giving side bending, tension, yes, do it. Then press in, yes, and now give the thrust. Good. Very good. Good. Yes, but it needs practice, don't worry. I didn't get it from the first time. Just get the right position. Show me the rotation of cervical spine. Thank you. Side, roll, sorry, be on your back. I don't want the head out of the bed, it's just a minute. Are you in the same class? Think you're going to. Okay. Not holding the face. Hold down. Slight rotation. Get this down. Your fingers up. Now side bending this. Try to get it going like this. Now this is push to the end and then rotate. Good. But too much rotation. Try to limit rotation slightly. Give the push. Yes. Better. But we need to do side bending, here tense, and now do the rotation quick. Yes. Need to do it quick. And the side, the other side. Yes. One thing, don't put your finger on his neck to choking him. Here, this. Rotate, side. Push this way, and then do the rotation. Quick rotation. Step. Okay. The other side, try to the other side. Yes. Thank you. Thank you for today. I hope I can give you some insight about the manipulation. Don't be afraid to do it. Okay? Thank you.
you so much, sir, for the worthy session. We're waiting for our chief guest of the day, the Director General of the university, and he's on the way. He'll be here in a couple of minutes. So we can stay calm. A very warm welcome to our chief guest of the day, the Director General of Hamdard University Islamabad Campus. We pay a huge respect and we are highly grateful for his guidance and support on the successful conduction of this event. I would like to call the Director General of Hamdard University Islamabad Campus, Mr. Imtiaz Haider, on the stage for the concluding remarks. Please, let me extend a
dear students, my faculty members, guests, and guest speaker, Mohamed Aldoliefy. Assalamu alaikum to everyone. Very good afternoon to everyone. So at the outset, I just want to express my thanks and acknowledge the efforts made by the participants for organizing this workshop, but at the same time attending the seminar as well. I'm especially thankful to our guest speaker, Mohamed Aldoliefy. I hope I'm pronunciating his right name, and for being with us as he has traveled all the way from Egypt, and for sharing his knowledge, experience, and his practices as well. So, extending my comments, I just want to add that although today's topic and workshop was very particular and specific to this one arm of physiotherapy, but physiotherapy as a discipline has evolved over the last 3 decades. And now and in future, there's a great demand for physiotherapy to help the patients for optimizing their quality of life by meeting up the challenges, physical challenges, and the illness that comes with age. I hope the students have gained enough knowledge for their professional growth, and I would encourage the department to organize such workshops in future as well, so that the students are exposed to their future intellectual growth as well. So once again, I'm thankful to the participants for being with us and organizing this workshop, and especially to Dr. Tahir Saab and my faculty members, and Dr. Amanullah Saab is not here, but he is the man basically behind the gun itself. And I'm thankful to Dr. Mohamed for sharing his knowledge with us. So I will be ending my vote of thanks with just one advice. Since we are facing a lot of challenges on the national level nowadays, so there is nothing to get yourself disappointed. Together, we can overcome the challenges as if we have the will, we'll overcome it. So never get disappointed, and if human spirit wills it, we'll overcome it. Thank you very much.